you. For our next speaker, we're going to have again Dr. Haazem Elbyrouti from Germany. He's going to discuss a novel extra anatomic course for infected aortoiliac access, the para-aortic gutter technique or routing. Dr. Beiruti.
So thank you, Mr. Chairman, and dear colleagues. It will be a pleasure to talk about a channel and channel route technique. Actually, infection in abdominal bifurcation, and especially in aortoiliac access, is related with high morbidity and mortality. So by those patients, the management is very difficult, especially if there is a history of redo operation or open surgical repair. So by these patients, there is the need, as we know all, for excessive surgical debridement and replacement. So as I said, a lot of material were suggested as homograft, femoral vein, pericardial graft, and omniflow for in situ bypass, and axillo-bifemoral for extra anatomic bypass. But as I said, first, not of all prostheses are suitable for all these patients. And another consideration is the proximity of grafts to the infection is related with high reinfection rate. That's why a lot of us, vascular surgeons, tend to perform extra anatomic, extra abdominal in sense of axillo-bifemoral bypass. But from other side, the patency by extra anatomic bypass have been showed that the data have showed that has a bad or worse data results than the intra-abdominal. So I would like to present our experience with this technique. Here, case one, patients who underwent stents implantation in EVAR as EVAR in aorta and in kissing balloon in bifurcation in the iliac position. Another patients with PAU and mycotic aneurysma in the aortic bifurcation. So how we perform this operation in laparotomy after finishing the proximal anastomosis, we will go to prepare a new channel, retrocolic retroureter. It means with a blend dissection and Caesar dissection, we perform a new channel laterally to the both lateral wall of the abdomen. And from there, from the retrogutter to the retrogutter region. And from the retrogutter region, we will direct our new channel to the groin. So it's not, I think you should, I will show you the post-operative CT scan. So here, as you saw, I perform from the right side here, the paragolic gutter, the graft is in the paragolic gutter, and from there it will be extended to the groin. So I will try to explain another time from here from the left side. As we see, through a new channel, we pass the limb, left limb, in this new channel to the paracolic gutter, and from there will be extended to the groin. So we performed this operation by 6 patients, 3 males. Actually, the cohort of patients, as you see, it's that are multimorbid patients. Duration of ACU was 2 days. In hospital stay was 17 days. There were no major complication. I had only 1 patient with graft thrombosis with successful thrombectomy and 1 late mortality. advantage, this method allows us to perform an aggressive debridement, time consuming, why we are not need we are not need for extra incision, feasible even in multimorbid patient. There is no need to reduce the diameter of the aorta like in the case of Omniflow prosthesis, and we can perform intra-abdominal, extra-anatomic, intra-abdominal and retroperitoneal reconstruction. Disadvantage, care should take not to injury the colon and ureter. That's why by all patients, I advise to implant ureter 1 day before surgery. And care should take also not to have a kinking in by this new routing. So this looks like our new technique, and as you can see here, we have through a new channel shown a new way from the aorta to the groin. Here we have a retrocolic, retroureter to the paracolic gutter, and from there to the groin. And we are far away enough from the infection field. So this technique shows a promise in cohort of patients with severe comorbidity, and long-term follow-up is mandatory. Thank you, sirs.